Our next speaker is Dr. AMIT PORWAL. He doesn't need any introduction. He is a member of the scientific committee of AIOS, and he's head glaucoma at Chowthram Hospital, Indore. And he is international level speaker in nearly all international societies and forums. Dr. Amit will talk about perfecting the operative art. Amit, please.
So, thank you, Vikram, for making me a part of this institutional course, and thank you, our delegates, for coming all the way in the morning for the first session. So, I'm going to talk about perfecting operative outcomes. So, what is perfecting operating outcomes? How are we going to master them? So, masterly and timely management of intraoperative steps is essential for happy and satisfied patients. So, to have a perfect surgery, what all things you have to take care, where all important points which have to be considered, I'm mentioning in this block. So, while you are giving a block, you make sure what you are comfortable with. Don't go by what your friends or colleagues or your practitioners are surrounding you do, whether they do a topical peribulbar or what. You decide with what anesthesia you are comfortable, and you do the surgeries with those only. Coming to the next step is incision. The length and width of the tunnel is very, very important, whether it is the main tunnel or the two side ports, because that is every step in phaco is going to affect the next incoming step. So you should concentrate on the length and width of the incisions which you are making on the cornea or the limbus. Capsule management is very, very important. Two important tips is, what I feel is you should always stay in the anterior capsule. Why? I'll tell you in the first videos which I'm going to show. And you should be aware of all the CCC techniques which are available, which are mentioned in the textbooks, and there are some modifications of the rexes which are mentioned in the literature where studies have done. So you should know all the types of CCC techniques. You should be able to know when to use a visco-adaptive, when to use a visco-cohesive, or when to use a combined. You should know all the chopping techniques. Again, don't go by what people say कि मैं तो सिर्फ direct chopping करता हूँ. No, whatever you are comfortable with. Even a direct chop or divide and conquer. The first step of a chopping technique is divide and conquer. Even divide and conquer does give an excellent result with least endothelial cell loss if it is done in a proper way. Coming to the cortex wash, I'm going to tell you how do we do the cortex wash. IOL loading and insertion, you have to pay important stress on the temperature, the visualization of the lens inside the cartridge, and at what angle you are inserting the IOL. That is very, very important. Again, washing the visco which is left behind the IOL, how to do it, I'm going to stress on that, and proper wound closure. So I'm just going to demonstrate a small video in which I'll highlight all the steps which I have taken. So you have to stabilize the eyeball and make sure the incision, your side port should not be too long and should not be too wide. If it is too long, when you are doing the bimanual steps, you'll have a lot of wrinkles around the cornea at the incision, and if it is too big, there will be a lot of wound leak, and sometimes there might be an iris prolapse. Staining of the capsule with trypan blue under an air bubble on a 1 cc syringe is very, very important. It gives uniform staining, and by staining the capsule loses its elasticity, and you get a better control of the vector forces when you are doing the rexes. I showed the main incision. You can use a uniplanar, biplanar, or triplanar, but again there should not be leak. You should know what is your sleeve size, and based on that you should master your incision. The technique of your rexes. This rexis marker which I showed you on the cornea, it is only for a time being. You just have to indent the rexis marker around the visual axis, and you can see the nice imprint is there. And now this will act like a guide when you are performing the capsular rexis. Important thing when you are doing a capsular rexis is always make sure the AC is adequately filled with viscoelastic substance. You should not overfill it. You should always have a flatter flap, and you should have smaller tears. You don't make larger tears. If you make a larger tears, there are chances of extension, and the rexis marker already gives a guide. Coming to the hydrodissection, you have to make sure that you visualize the wave, and sometimes a multiple hydrodissection from different quadrants and a delineation help you in mobilizing the cataract from the corticocapsular adhesions. Whenever your visuality is obstructed, always use visco. Don't tell your sister to go on pouring saline on the cornea, because that is more epithelial toxic. So once you just put visco, and your view becomes very clear. Again, when you are doing the phaco, important thing to realize is first check the flow outside the eye before you put the phaco probe. Always make sure that the two irrigation ports are at 3 and 9 o'clock from the bevel, and whatever technique you are comfortable with. I am more comfortable with my stop and chop technique, and it is not like that I do only stop and chop. I had an IC yesterday where I showed that if you are not getting a good crack, you should not be ashamed to convert into a divide and conquer also. Divide and conquer is not an inferior technique, it is a very good technique. Only thing you have to learn is your tip should be adequately exposed. You should have you should embed the phaco tip into the cataract to get a chop. whether it is a stop and chop or a direct chop. If you don't embed the phaco tip adequately into the substance of the cataract, you will always leave the hold. So as it is said, by doing a short course of 20-25 phacos, you won't be able to master. Important thing to learn and to master your skills and to refine your skill is you always record your surgeries. Whatever surgery you record, you visualize it later on and see where you could have improved. This way, the mastering the surgical techniques will be very, very important, and this will give you a good guide that what is needed. So recording systems are not expensive. Even with 5,000 or 6,000 rupees, you can start recording it. Coming to the bimanual technique, or the even if you want a coaxial technique of cortex wash, the important thing we should remember is you should never pull it perpendicularly the adhesions. You should always strip it by giving a bit of diagonal movement so that you don't have any zonular dialysis. Always I prefer the bimanual technique because I don't have to put more stress on the main wound, but if I go with the coaxial, I would recommend a J cannula so that the subincisional cortex can be aspirated without much stress. Now coming to the injecting the IOL, you should have adequate depth AC tightness. If it is too tight, the IOL will, the visco will go on coming out and you will have more resistance. You see in this, when I was injecting the IOL, the direction of the cartridge into the AC is very important. If you are doing the wound assisted, it is a different thing, and if you are doing into the AC injection, then the direction of the cartridge is different. Coming to the visco wash, always master this. This is very easy. It is not difficult at all. Just push the IOL optic a bit in to the opposite side and lift it up with the aspiration port, and then you can just rotate the IOL 3-4 times, and all the visco that is there behind the IOL can be washed. This you should master it. You should, by doing, and you should start this step in small steps, because what you need is a good foot control when you are doing this. You see, multiple rotations can be done, and all the visco that is there behind the IOL can be washed. Coming to the wound hydration, if your wound is adequate, just by stromal hydration, your AC will get closed and this will be tight. But if at all there is any leak, you can always check that leak by putting a drop of trypan blue near the incision site and see if there is any fluid drainage. If it is there, then you have to do again hydration, or what you need to do is basically suturing. So as I told you about the incision related technique, so when I told you the length and the width of the incision is very, very important. In this case, you see my side port was too long. Even my incision which I am taking is too long and it is too corneal. So when this type of incisions you have, when you do your procedures, there are a lot of folds on the cornea, and that obstructs the visibility and your surgery becomes difficult. So you have to always make sure, you see, the wound goes on hydrating when you are doing the surgery, and you are not able to see the cortex which is there below this edematous area, and this edema has occurred because of longer incision and tighter incision. So then I had to make one more side foot to aspirate the cortex which was there subincisional, because I was not able to visualize it properly. So these are the complications if you are not doing it properly. In this case, you can see I did a rexis. I was overconfident that my rexis is finished. Okay, rexis is finished. I didn't take out the flap. I started doing a hydro, thinking that the flap has come out, and I mechanically, you can say at the spinal level, you just start your surgery. See, I just did the hydro dissection. I rotated the cataract 5-6 times, and I started my phaco. So I am doing the phaco, and suddenly, what do I see? Are you able to observe anything? See, there is a capsular flap which is coming near the phaco tip. So when this capsular flap started coming to the phaco tip, then I realized that the rexis was not complete. So you have to understand that every step is important. These are just a few video clippings of IOL related. If your temperature of the IOL, especially for hydrophobic IOL, is not maintained properly, then there are chances that it might shoot away. In this case, the other video, it tumbled. So I am trying to re-tumble the lens into the AC only and put it in a proper position. It was injected upside down, because when I injected the IOL, it rotated, and now I am showing you the maneuver of how to tumble the lens into the AC without taking it out. Very easy, but you have to master it. So you have to be very observant when you are putting the IOL. So this is another video which I am showing you how this hydrophobic IOL can behave. Even after you load the IOL, you have to always observe the IOL cartridge into the microscope in low magnification to see that no haptic is getting stuck. You can see in the video on the right side, there was an optic crack. So if you have any of these crack, then you can see in this, the crack is visible. So if you have any of these things, then your surgery becomes difficult, because you have to explant these IOLs. So the key to all these steps which I spoke is mentioned in this particular chart. So which all things you have to adapt and how you are going to master. Thank you.
Thank you. Thank you, Dr. Amit. That was really a perfect surgery. Mastering each step individually will lead to a perfect surgery.